This lecture provides background on the history of child health politics and policy in the past 40 years. My name is Kate Johnson. I'm a research assistant professor of pediatrics at the Geisel School of Medicine at Dartmouth, and I'm also a lecturer in health policy at the George Washington University. And this lecture was prepared in preparation for additional work we're going to do in January of 2015 regarding disability policy for children. I'm going to talk to you about an overview and methods and a theoretical framework for a large study that I conducted. I'm going to review with you the case study on child health coverage policy since 1977 in this online lecture, and when we're doing face-to-face work in class, I will be giving you a lecture about the case study on childhood disability policy. And I'm also going to talk to you about the concept of framing, which is a political science, social science concept, and how child issues have been framed. So the name of my study was, working title was From Chap to Chip, and you'll know why those two words in a moment. And the real question of the study was, how did issues get on the agenda, and what were the lessons and legacies of policy action? It was a qualitative research project, a very large one, that including looking at congressional hearings over a 20-year period, print archives from newspapers, documents from experts, preparing large text files encoding for nearly 200 terms and concepts, and developing ideas and matrices. The primary case studies in this work were child health coverage, childhood disability, childhood immunization, and home visiting, and my work was supported primarily by a Robert Wood Johnson Foundation Investigator Award in Health Policy. I want to start first by talking to you a little bit about the Kingdon theoretical framework. And John Kingdon is a political scientist whose work on policy issues and understanding why some issues get on the governmental agenda at specific points in time has been widely discussed over nearly 50 years. His book is often used in political science courses, and sometimes entire courses are taught to understand Kingdon. It's a way to think about what happens before an issue gets to the point of national legislation or being adopted by the law. It's not a random process. And Kingdon describes it with three process streams. One is the problem stream, typically visible actors such as legislators who might define, or a president who might define it as an issue for the agenda. And then there's a policy stream where policy alternatives are formulated. Often this is members of the policy community, and they write white papers, and they think about this through research studies and think tanks, and there's a lot of discussion and back and forth about what the right policy solutions might be. And then in the political stream, it's shaped by public mood. Do people care about this issue? Election results, what has salience, and what ideological shifts are underway. So if you think about it, in the policy stream, policy problem identification and policy remedies are being generated. And in the political stream, we're thinking about the social context and whether or not there is political will. But Kingdon makes a very strong case for the fact that where those things come together, where a problem has been identified as a national problem, a policy remedy is ready, people believe in this remedy in the social context, and there is political will to adopt that kind of policy, you have a window of opportunity. Sometimes it's very brief, maybe no more than a few months, maybe no more than a year, but those windows of opportunity are when big things happen and things get on the national policy agenda. So in my study, we looked at some of these issues from the point of view of the Kingdon framework and at distinct time periods. And these are the coverage time periods, and I'm going to talk to you about these. One, the Children's Health Assurance Program from 1977 to 83. Then you can see a Medicaid expansion period, a Medicaid block grant period, the CHIP period, the CHIP implementation and reauthorization period, health reform, and the Affordable Care Act period. And I'm going to make the case to you that there were three main forces that shaped these policies. One was budget priorities. A second was social values and public opinion about children and families and health also, and about policy learning and legacies, a term that we'll explain later. So in the base period, really the CHAP period from 1977 to 1983, the Children's Health Assurance Program was proposed in Congress. The Carter White House submitted legislative proposals, and organizations such as the Children's Defense Fund led the advocacy. But there were problems. There were divisions over whether or not there should be how much more to expand Medicaid versus national health reform, and whether or not children should go first. In addition, it talked about coverage for pregnant women, and abortion proponents and opponents fought over whether or not there would be funding for abortion in this Medicaid expansion. It laid the basis for incremental changes in the 1980s that I'm about to describe. But larger issues of national health reform overshadowed child health. And when President Reagan was elected, the political mood changed and no major health policy changes were enacted during that period. So basically in the Carter administration, you can see here the summary of those forces that I've just described to you. Let's focus here for a moment on the legacies and lessons. CHAP defined the key components that we'll talk about in the next phase. They were all laid out in one bill and later dealt with incrementally. The congressional staff and interest groups who were positioned around CHAP carried forth over perhaps the next 20 years as the leaders on these issues. And the focus was on pregnancy, not on family planning or abortion as a result of these issues. Between 1984 and 1990, a major series of expansions for children's health coverage were adopted for Medicaid. Child health was redefined as a national problem by Congressman Waxman, Senator Benson, President Bush, and others, and an incremental series of problem definitions and policy proposals were put forward. There was a lot of comparison, and a lot of this was driven by concern over infant mortality and our poor outcomes. The Children's Defense Fund defined Medicaid as the approach, and there were a lot of committees and commissions looking at children's issues who were involved in shaping these issues. In the political stream, there was Democratic control of Congress and a national mood that was sympathetic to child and families issues. As a result, millions of additional children and pregnant women became eligible for Medicaid, and the Medicaid benefits were enhanced, particularly for children, and the state response led to variable results. How enthusiastically states adopted these changes made a difference in what outcomes they received. So here you see again a summary of what we've just covered in the chart, but looking at lessons and legacies, these incremental expansions had phased in coverage. It started with, okay, first it was the pregnant women and the babies, and then children up to age 6, and then gradually covering children up to age 18. The congressional leaders were strategically positioned, and some of them went at this again and again and again, coming back to particularly Congressman Waxman in the House, also Congressman Miller, both of whom recently retired or announced their retirement, as well as Congressman Hyde, who set out a framework of saying this was not about abortion with his conservative, right, anti-abortion position and respect in that area. And again, the focus started on pregnancy and infant mortality, but carried to expansion of coverage for children up to age 18. Just to give you a little sense of how bipartisan these issues were in the 103rd Congress when major legislation was enacted. If you look on the left scale, it's from 0 most conservative to 100 most liberal, and it's based on 18 sets of ratings that were used by Brady and Bolden. This is not just were they conservative or liberal on children's issues, but were they conservative or liberal overall? How were they ranked? And what you can see from Dole and Hatch and Domenici up through the moderates in the middle to Moynihan, Harkin, and Kennedy, who were seen as most liberal, there were people all across the political spectrum who were willing to stand for children and help to expand Medicaid for pregnant women and children. In the Clinton health reform period, there was a proposal that under which near poor children would have lost some benefits. There was an argument that we could not do everything for everyone, and children with disabilities had some of their coverage threatened. And out of that grew an organization many of you know as as family voices. Child advocates, however, had to join the Long-Term Care Coalition and try to secure a piece of resources from the elderly in order to get into the political debate. There was only one big vote on health care reform. It was in the Senate in the Clinton era, and it was about maternal and child health. And when it failed, members of Congress, particularly in the Senate, knew that there was no going forward with the Clinton health reform legislation. So next came a period of thinking about Medicaid block grants. It was defined as a national problem by Republican governors who argued that there were too many federal rules. There was intense partisan debate, and the White House played a major role. There was a lot of fragmentation in the health policy community about whether or not to support the Medicaid expansions. And in the end, child advocates joined with poverty advocates, faith-based organizations, senior citizens advocates to preserve the entitlement. Welfare reform was viewed by President Clinton as more important than Medicaid reform, but this left a legacy, and it left a legacy we'll talk about more in the context of CHIP. So it was vetoed by the president. It did begin to address the saliency of whether we needed more child benefits or more child eligibility, and eroded support for the child health benefits approach in Medicaid. The lessons and legacies about delinking Medicaid from welfare and having the block grants principles tested and refined, and having it be a fact when we get to the next phase, states had more power and leverage in asking for autonomy and control over what would be adopted. So in the CHIP enactment era, Senator Kennedy defined children's health insurance as an incremental step. The National Governors Association and the House Republicans defined block grants as the remedy to cover more children. And children's health advocates were divided on this issue, whether it should be a block grant or it should be Medicaid. But in the end, it was clear that only a block grant could be actually adopted. There was actually a way of talking about this, and the politics of morality is what political sciences would call it, about working parents deserving more coverage, and also using some emphasis of tobacco money to say, did we want to help Joey or did we want to help Joe Camel? As a result, in the policy outcomes, millions of additional children became eligible for health insurance. CHIP embodied the block grant approach. We came up with a two-tiered public coverage system for children, CHIP versus Medicaid, and there was a great devolution of power to the states in terms of determining how CHIP coverage would be enacted. The legacies of this is to have more private insurance options being considered, and that affects us all the way up to the Affordable Care Act. But this is another example of bipartisan support, with Senators Kennedy and Hatch being the prime drivers of this, and we'll talk more later about how their emphasis on the deserving, working, low-income families saved the day in getting this adopted. Between CHAP and the reauthorization of CHAP, an act known as CHIPRA, there were protracted political fights, and there were very few strong champions who could not get forward in a bipartisan, with a lack of a bipartisan climate in Congress during these years. It was almost a decade of strong implementation, but not major, and being able to define CHIP as a success, but having trouble when it came to reauthorization. There was no bipartisan policy solution. President Bush failed to sign the reauthorization, but when President Obama came in, it was one of the first laws that he signed. As a result, the block grant approach continues through now 2019, and the funding continues only through the October 1st of this year. So the fate of CHIP hangs in the balance again. But at the point of CHIPRA, it was continued through 2013. Performance bonuses were offered to states. There was an option to cover pregnant women, and there was a great deal more emphasis on quality measurement, but still no standardized guaranteed benefits for children. Again, jumping down to the limitations here first. States wanted no more Medicaid expansion. The guarantee of the gold standard child health benefit under EPSTT was lost, and there were lessons and legacies from this about the block grants principles grounding the work for future healthcare reform. The sky did not fall using private plans under CHIP, and therefore the whole idea gained saliency. Looking forward to the Affordable Care Act period between 2010, its adoption, and in 2014, fully implementation. The problem definition was to get over 50 years of a political fight over we ought to have a more universal approach to health care. It built on the Massachusetts model and Republican think tank proposals. It was defined as universal to be achieved through public and private approaches. Children's health advocates did not need a big coverage push. 90% of children were already covered, but they fought for things like prevention services, home visiting, and so forth. The private health plans saw an opportunity. They defeated the public option that was in the initial Obama proposal, and basically all of the expansions in the Affordable Care Act for the near poor and working class families are all private insurance purchases done by states, but still money through private companies. The providers also stood with President Obama and helped to pass this. In the political stream, President Obama set this out as a priority for the beginning of his first term. There was no real bipartisan solution, but obviously the fact that Republicans have tried to repeal the law repeatedly is an indication of that. And there have been Supreme Court challenges. The last decision nullified the Medicaid mandate, and there will be another important Supreme Court challenge considered this year. The policy outcomes were the adoption of the Affordable Care Act with many elements and major coverage expansions for uninsured adults, particularly low income and working men and women of childbearing age. So for young families, this really made a difference to have the parents and single adults covered. The benefits are within broad standards, but a lot of decisions were still left to states. That's a legacy of CHIP. And emphasis on prevention was visible, but money didn't always follow the commitment. And only half of states expanded Medicaid in 2014, largely not those that had conservative Republican governors. So, looking here at health reform, the lessons and the legacies, the privatization of the health system widens and deepens. There's greater public mistrust of government, and there were small but valuable gains for children, but they were primarily used as a loss leader. This was not about children. This was about covering the adults who had been left aside earlier. Let's talk now a little bit about framing policy issues. Baumgardner and Jones talk about this as issue definition that has the potential for mobilizing the previously disinterested. For many years, and sometimes in many cases yet, social investment frame was the one that was largely used around children's issues, that children were innocent and blameless, that current expenditures prevention would save money later, and that the well-being of all children is related to our nation's economic future, that the nation would only do well if all children did well. There was a reframing in terms of a family values perspective in the early 1990s. So the minority chapter of the National Commission on Children report said, as important as financing issues are, we believe that the weakening of the structure of the American family may be an even greater threat to the health of children. And even in the liberal Senator Kennedy, in describing the children's health insurance proposal, didn't talk about this being a social good. He framed it in what was important for families, and by saying their parents work hard, but all their hard work doesn't buy their children the protection they deserve. The legislation imposes no new governmental mandates. It does not substitute for family values. So the frame really shifted at every level on the larger political theme. Shifting then to talk about what we've achieved over the coverage period. We had the number of uninsured children drop over a period, let's just say between the enactment of CHIP and just into the enactment of Obamacare, for the uninsured children, it was an almost 15-point difference. These are all significant differences in each of these. Having a usual source of care, it's a small number, but it's significant across all children in the United States. Having a doctor visit in the prior 12 months, significant in that case again, and having unmet healthcare needs due to the cost for low-income children, for poor children, again, a significant, even if the number looks small. So we made huge changes, and this really begins to give us an opportunity to frame success in terms of what's actually been achieved. At the same time, we've had no universal child health policy, and we've failed to address the needs of all children. And Medicaid became Medicaid versus CHIP, a shift to entitlement toward a lump sum payments to states. In the Supplemental Security Income Program, there were multiple redefinitions of childhood disabilities, focusing on the, quote, truly needy or the more deserving children, as opposed to a broad functional definition. And when it was attempted to have universal vaccine purchase, we ended up with the Vaccines for Children program, which offered only the poor and uninsured, not even all underinsured children, the federal purchase of vaccines. We just did not have the political will in the past 30 to 40 years to adopt universal child health policies. So what's coming? In December of 2014, there was a special issue of Health Affairs, which is all about children. And here are just 3 headlines from that. One from Rosenbaum and Kenney, that we need health policies that ensure access to high-quality care that meets children's physical, behavioral, and developmental health needs. That we cannot continue to ignore adverse childhood experiences, risks, traumas, developmental challenges, which have lifelong consequences in terms of chronic illness, mental health, and a variety of other things. And third, that we need policies that integrate educational, health, social, and economic initiatives designed to promote child and family health and well-being, especially at the community level, where we need these things to come together. I've given you a list of selected references. Some of these are books. If you're really interested in the long frame history, read Theda Skocpol's Protecting Soldiers and Mothers, about the origins of social policy in the United States. It's all about moms and babies. If you're interested in the Kingdon book, the reference is there, as well as a history of the Title V program by Brosco, and The Politics of EPSTT Policy by Alice Sardell and myself, which will give you the practical application of Kingdon theory to EPSTT and Medicaid expansion during this period. I hope you enjoy this lecture. You've got the fundamental concepts of Kingdon and framing going forward, and we will talk in our face-to-face meeting about how these apply to the case of childhood disability policy.